are going to look at the ventral wall defects. Now, there are two important defects that we need to look at. One is called the gastroschisis and one is called the omphalocele. What happens is in in the embryology, why these defects basically occur during early development, the embryo folds in three directions. Okay, there are three main direction foldings. If we look at this image, we can see that there is a rostral folding, which is the head fold, right? So your heart is here, and this is your head fold. This is the area where the heart is, this is the septum transversum. All of it falls down here, right? It goes on to create a head fold, a rostral fold. Any sternal defects or any defects in the head folding is going to lead to sternal defects because the sternum is near the head, right? And the ectopia cordis. Then we have a lateral folding. Lateral folding is, you can see, lateral folding is going to be when the area anterior to this and posterior to this is going to enclose around this area, right? So if I this is still the rostral fold, right? So can you imagine that there's going to be a lateral folding also, where the you can imagine um, the cavity here is going to sort of extend itself anteriorly and posteriorly and create a lateral fold. So any problem with lateral folding or leads to basically um, wall defect. So any failure of proper fold closure leads to ventral wall defects, right? And then we have a caudal tail fold. So this is your caudal tail fold. And if any problem goes wrong here through the caudal tail fold, you get something like bladder exstrophy. So we're going to look at the lateral folding here. Now, if there's a failure of proper closure, we get two ventral wall defects. We get gastroschisis and we get omphalocele. Now, let's look at them. The core difference is, what is a gastroschisis? A gastroschisis is basically a para-umbilical abdominal wall defect. So what happens is the bowel herniates directly into the amniotic cavity because there's a failure of proper closure, right? So this bowel basically herniates directly into the cavity. It's not covered by a membrane. This is the core difference. In gastroschisis, this is not covered by a membrane and it's not covered by any peritoneum or amnion, and it's usually right sided. So in this image you can see that the default is the problem is right sided. The bowel looks a little inflamed and it looks thickened, and it's not commonly associated with any chromosomal anomalies, but it has a good prognosis. Okay, so what happens is, why there's no membrane here, it's because the defect is outside the umbilical ring, it's not inside the umbilical ring. That's why there's no membrane on it. Now you have something called the omphalocele. Omphalocele is basically herniation of the bowel um, inside through the umbilical ring. So herniation of the bowel through the umbilical ring is when you get the omphalocele. This is covered by membrane, and it's covered by membrane, and that membrane is peritonean and amnion. Both cover it. It's usually present in the midline. Here you can see it. It's in the midline. This is usually right-sided. Now, this one does has association. It's here you can see it's not associated with other anomalies, only 10%, but it's very common to see this associated with other anomalies like the cardiac, genitourinary, or neural tube defects. There's a membrane present, so you can, whenever you see a membrane present, you think about a chromosomal anomaly. This is also, omphalocele is also very common with Beckwith-Wiedemann syndrome. It's also common with trisomy 13 and 18. Okay, so remember that the umbilical cord is adjacent to the left side of the defect here. So this is the umbilical cord, it's adjacent to the left side of the defect. But here the umbilical cord is attached to the sac. So this umbilical cord is attached to the sac. The herniated viscera in the gastroschisis, you can have found small bowel, stomach, abdomen, small bowel, stomach, and colon. Same thing is here. You can find small bowel, stomach, colon, but you can also find the liver in omphalocele. Then there's a malrotation in gastroschisis, but there's also a malrotation in gastroschisis. The bowel character, the bowel that you can see outside, is inflammatory, edematous, and thickened. But the one in omphalocele is normal. Enteral nutrition in gastroschisis is delayed, but in omphalocele it's normal. Now, the sac is basically, there's never a sac present, right? But in omphalocele, there's always a sac. It's covered by this sac membrane, which is made of amnion and peritoneum. The defect size in diameter in the gastroschisis is just 2 to 3 centimeters, but in omphalocele, it's 2 to 15 centimeters, right? So there's a sac present. There's a sac not present in gastroschisis, but it's always present in omphalocele. Gestational age. This happens with prematurity, but omphalocele happens at term. Okay, that is something. Now let's just read from first aid. So, developmental defects due to failure of rostral fold closure, like sternal. Okay, so whenever you get developmental defects due to rostral fold closure, it's sternal defects, ectopa cordius. So, if we have a rostral fold closure problem or failure, we get defects like sternal defects, like ectopia cordis. And if we have a lateral fold closure, we get omphalocele, gastroschisis, or if we have a caudal fold closure, we get bladder extrophy, right? Can you appreciate that this is a congenital abnormality of the sternum due to failure of fusion of the paired sternal bars during embryological development? So, normally, your sternum bars get, can you see these sternum bars? They're supposed to meet in the area in the middle, right? But if that doesn't happen, the failure of fusion of the paired sternal bars during embryological development, the sternum develops from two mesenchymal sternal bars. So there are two mesenchymal sternal bars, and the sternum develops through it. So usually these bars migrate medially and fuse in the midline, and fusion normally occurs craniocaudally during the 6th to 9th week of gestation, but a failure will cause a sternal cleft or agenesis. Now you have you have different types of these. So you have a complete sternal cleft where the entire sternum fails to fuse, okay, and then you may have a superior cleft or an inferior cleft. So this is an inferior cleft, and this is a superior cleft, right? So you have a failure of fusion inferiorly here, and you have failure of fusion superiorly here. And then there's something called as complete absence of sternum. This is rare, but this is also very severe. So that this is what is sternal defect. So these sternal defects are common with the failure of rostral fold. Now there's something called as ectopia cordis. Now this is the ectopia cordis. This is a rare congenital condition where the heart lies partially or completely outside the thoracic cavity. This is because of a failure of a ventral body wall closure or a failure of sternal fusion. So this often overlaps with severe sternal defects. Um, Moving on to the next problem I just showed you guys. The next problem they've mentioned here is the bladder exostrophy. This is a congenital anterior abdominal wall defect in which the posterior wall of the urinary bladder is exposed on the surface of the lower abdomen due to failure of midline closure. So it's basically caused by failure of mesodermal migration into the infra-umbilical abdominal wall, and this leads to non-formation of lower abdominal wall. It leads to non-closure of the anterior abdominal wall, and it's related to abnormal development of the cloacal membrane, and this occurs around 4 to 6 weeks of gestation. So I'll show you something here. This is also the same picture shows you the bladder exystrophy. So it's an inverted bladder basically. It's a congenital anterior abdominal wall defect in which the posterior wall of the urinary bladder is exposed on the surface of the lower abdomen due to failure of midline closure. And this is because of failure of mesodermal migration, into which area? The infraumbilical abdominal wall, this area. And this leads to non-formation of the lower abdominal wall, non-closure of the anterior bladder wall. So what's basically exposed? The posterior wall of bladder is exposed. There's a red mucosal plate visible, as you can see here. This red mucosal plate. The ureteric orifices may be seen spurting urine. Pubic symphysis is widely separated. That is something you should know also. Okay, next. Okay, so we've now seen gastroschisis, we've seen omphalocele, and gastroschisis, you can see there's an R, so it's present on the right side. It's para-umbilical, and omphalocele, since it has an M, it's present in the midline and it has membrane covering it. That's a little bit of a help to remember you this thing. Now there's something called as congenital umbilical hernia. This is a delay of umbilical ring to close spontaneously following physiological herniation of midgut. So what you get is basically a patent umbilical orifice, right? This is covered by skin, as you can see here. It's often reducible, but protrudes with increased intra-abdominal pressure like crying. It may be associated with congenital disorders like Down syndrome, congenital hypothyroidism. So these small defects usually close spontaneously, but we must know that they happen also. So this is an umbilical hernia. It's a soft lump under the skin around the baby's belly button. This basically happen when tissue from inside your baby's abdomen, the tummy, pushes through the opening, pushes through an opening in their abdominal wall. So I'm going to show you another picture here. Can you see this? So this is basically a congenital umbilical hernia. It's a condition where the abdominal contents herniate through an incompletely closed umbilical ring, but are covered by normal skin. So the key differentiator is that the skin is present, and it's due to failure of complete closure of the umbilical ring after return of the midgut. It occurs after physiological herniation has already resolved. The developmental timing is late fetal period or at birth. Physiological herniation normally occurs around 6 to 10 weeks, but then it returns. So, umbilical hernia is a defect that persists after the return, right? So, the defect site is basically the umbilical ring, the covering is skin and subcutaneous tissue, contents are small bowel occasionally, but omentum is present. The neck is wide, that's important clinically, and it's a soft, painless bulge at the umbilicals. It becomes prominent on crying, coughing, straining, and it is reducible, but the impulse is seen on crying, right? Now we have something called the tracheoesophageal anomalies, right? Now what happens is, in the normal development, what happens is the foregut divides into an anterior trachea and a posterior esophagus, and this is normal. So anteriorly you get a trachea here, and the esophagus is posteriorly present, right? And this is normal development. Now what happens is there's a failure of proper separation of the esophagus and the trachea. So basically, esophageal there are different types of these failure of separations between these between the trachea and esophagus. The most common type is esophageal atresia with distal tracheoesophageal fistula. Okay, so we're talking about this one, esophageal atresia with distal tracheoesophageal fistula. This is the most common one. This is when you have a blind pouch in the upper esophagus. This is a blind pouch, right? Nothing is going down here. And then the lower esophagus is connected to the trachea. So the problem is that the fetus can't swallow amniotic fluid. Since the fetus cannot swallow amniotic fluid, you get polyhydramnios, right? So after birth, the first feed leads to choking, drooling, coughing, vomiting, And there's cyanosis. There's a decreased oxygen in the baby due to aspiration and laryngospasm. And there's a prominent gastric bubbles because air enters the stomach from trachea via the fistula. Can you see the gastric bubble here? Because the air is entering the stomach via the fistula, right? This is what we call a prominent gastric bubble because air is entering the stomach through the fistula. There's a failure to pass the nasogastric tube into the stomach. Obviously, um, there's a failure or there's a blind pouch here, so there's no way you can pass a nasogastric tube down, right? It's associated with vacteral defects. These vacteral defects, VACTER, this basically means V means vertebral defects, A means anal atresia, C means cardiac defects, T is for tracheoesophageal fistulas, E is for esophageal fistulas, and the T is for tracheal fistulas, R is for renal problems, renal defects, and L is for limb defects. So it's very common to see this with other vectoral defects. Another important variant is the pure esophageal fistula. So this is the pure esophageal fistula. This is where you have no fistula, and the upper lower esophagus are both blind. So you'll see a gasless abdomen here. There's no prominent bubble here because no air reaches the stomach. Here the bubble is normally supposed to be small, but it increases because the prominent gastric bubble increases because you get air through the trachea. The air comes into the esophagus and goes down into the stomach. Now there's an H type pure tracheoesophageal fistula. This is where the esophagus is intact, but there's a small fistula between the trachea and esophagus. And it's connected like an H, right? So this looks like a letter H. In this, you get recurrent aspiration, and there's often coughing during feeds, and is often missed during birth. So in the pure one, you have a gasless abdomen. In the other two, you have a prominent gastric bubble. So whenever you have gas in the stomach, you'll see a tracheoesophageal fistula. Whenever there's no gas, you're going to see a pure esophageal atresia. This is where both sides are blind, right? Moving on to hypertrophic pyloric stenosis. Now, what is this? As far as I remember, this was a very commonly questioned topic, hypertrophic pyloric stenosis. This is the most common cause of gastric outlet obstruction in infants. Palpable olive shaped mass due to hypertrophy and hyperplasia of the pyloric sphincter muscle in epigastric region. There's visible peristaltic waves and postprandial non bilious projectile vomiting at 2 to 6 weeks old. Now let's stop here because this is enough to understand, right? Now, what happens in pyloric stenosis is basically you get hypertrophy or and hyperplasia both of the pyloric sphincter muscle. So this is the pyloric sphincter muscle, and you get pyloric stenosis here. Why? Because there's an increased growth, there's an hypertrophy, increased cell size, and hyperplasia also increased number of cells. So this is like the cells here overgrow, the wall here overgrows of the pyloric sphincter muscle, and it causes gastric outlet obstruction. Nothing can get out because this is completely blocked because of the hypertrophy and hyperplasia. This classically happens in a 2 to 6 week old infant, and usually it's a firstborn male. There's a history of macrolide exposure associated with pyloric stenosis, basically medicines like erythromycin. So what happens is, so you can see that this is where the this is a healthy pylorus, where the sphincter has enough space for the gastric contents to come out and go into the next part, the duodenum. And here you can see that it's stenosed, right? So this area is basically stenosed. It's so tightened that there's an obstruction. So what do you get? You get projectile non-bilious vomiting. It's non-bilious because the obstruction is proximal to ampulla of water. Now the ampulla of water is down in the middle of the duodenum, right? And that's where your bile duct is coming in. But it's non-bilious because this obstruction is way before the bile even enters the duodenum, right? So this problem is where the stomach is leaking its or giving its content to the duodenum. So there's a non-bilious vomiting. The vomiting occurs after feeds. The baby is hungry after vomiting, and there are visible peristaltic waves. You can see those. There's a palpable olive-shaped mass in the epigastrium, So in the epigastrium, you're going to see a palpable olive-shaped mass, most precisely in the right upper quadrant. Here, you're going to see a palpable olive-shaped mass, and a metabolic abnormality, which is like an exam favorite question, is you get hypokalemic, hypochloremic metabolic alkalosis. Let's try to understand this a bit because they do ask this on exam questions. So you get hypokalemic, hypochloremic metabolic alkalosis. Why? Because this loss of gastric HCl, right? Now, if you're losing the hydrochloric acid of the gastric area, you get alkalosis. And then there's volume contraction, so that worsens alkalosis. And the potassium shifts intracellularly, so you get hypokalemia, right? So basically, why do you get alkalosis? Um, the infant vomits gastric contents repeatedly. That means there's loss of the hydrogen ions, basically acid. As a consequence, losing acid, the blood becomes more alkaline, and this leads to primary metabolic alkalosis. So losing acid is the same as gaining base. Now there's volume contraction. Volume contraction, this is something that's very, very tested. So this loss of fluid. Loss of fluid leads to decreased effective circulating volume. Now there's a decreased effective circulatory volume, so what happens is the kidney responses through the RAS activation. There's a decreased volume and increased renin and increased angiotensin 2, which leads to an increased aldosterone. So the volume is decreased, renin increases, which increases angiotensin 2, and that increases aldosterone. So aldosterone effects in kidney basically affect in creating an increased sodium resorption. So increased sodium is reabsorbed, and increased hydrogen secretion, more hydrogen is secreted, and more potassium is secreted. So there's this even leads to even more hydrogen lost in urine, and the alkalosis becomes even worse and sustained. So why the kidneys fail to correct alkalosis? The kidneys prioritize volume over pH, right? So for the kidneys, volume is more important than the pH. So it sacrifices hydrogen ions and potassium to save the sodium and water. This is why alkalosis persists. So that is something that explains why the alkalosis persists, right? I hope you understood that the volume is decreased, renin is increased, renin increases angiotensin 2, which increases aldosterone, which leads to sodium reabsorption and hydrogen secretion and potassium secretion. The kidney is losing the hydrogen and potassium in exchange for sodium reabsorption and water. So the kidney likes water and sodium more than it likes pH. It doesn't care about pH. It's trying to conserve the volume. Now, why hypokalemia occurs? There are two mechanisms here. The first one is aldosterone mediated potassium loss. So, aldosterone leads to potassium loss through the collecting duct, and this leads to renal potassium loss. The second mechanism is the intracellular potassium shift. This is very important. So, in alkalosis, blood pH increases and hydrogen ions decreased in the extracellular fluid. So, in the extracellular fluid, hydrogen ions decrease, and the body wants to maintain electroneutrality. In order to maintain the electroneutrality, hydrogen ions move out of the cells to buffer alkalosis. Okay, so the hydrogen ions move out of the cells to buffer this alkalosis, and the potassium moves into the cells to maintain charge balance. As a result, the serum potassium is decreased, and this leads to hypokalemia. This is a shift, right? This is not a true potassium deficit initially, but it becomes a true deficiency with ongoing vomiting, because with more and more vomiting, you're basically vomiting, losing the acids, causing alkalosis. There's a volume depletion, which leads to contraction alkalosis. Basically, aldosterone increases. There's an hydrogen and potassium loss in urine. Sodium in water is trying to be conserved. This worsens the alkalosis, and then you get hypokalemia also. Now, why we need to understand the hypochloremic part also. What is gastric acid? Gastric acid is basically HCl, which is basically hydrogen ions, and chloride, right? So the vomiting does not selectively remove the hydrogen ions, it removes both. It removes the hydrogen and chloride ions. So as a result, you cannot really lose the acid without losing chloride. So chloride is basically also lost. Now, what happens is chloride is required to excrete the bicarbonate. In the kidney, the bicarbonate excretion depends on chloride availability. In the beta intercalated cells, hydrogen carbonate is excreted into the urine only in exchange for chloride. This is a pendrin exchanger. So if chloride is low, kidney cannot really excrete the hydrogen carbonate and alkalosis persists. This is why you get hypokalemic, hypochloremic, metabolic alkalosis. So I really hope you were able to understand that. This is a little the ultrasound image. Can you see that this is the muscle thickness here? The muscle is so thick here, the channel length, you can see the diameter is all obstructed because of the muscle thickness. This is hypertrophic pyloric stenosis. The ultrasound shows thickened and lengthened pylorus. So the pylorus is pretty long and it's really thick. The muscle is pretty thick. Treatment is surgical incision of the pyloric muscles. This is called pyloromyotomy. It's more common in firstborn males. I said it's associated with exposure to macrolides like erythromycin. There's a history of it being associated to erythromycin use. Results in hypokalemic, hypochloremic, metabolic alkalosis, secondary to vomiting of gastric acid and subsequent volume contraction. So I'm going to stop the video here and I'm going to make a new one with the next part. I hope this was helpful, guys.